Greeting from ECS Heart. My name is Omar Al Falasi. I'm a consultant electrophysiologist from Shiekh Khalifa Medical City in Abu Dhabi. Today we're going to talk about a very frequent diagnostic test, most of the time coupled with the curative or the ablation part. It's the part that we call the electrophysiological study. It's a procedure where the exam is done under local anesthesia. Most of the time the patient is conscious. We take the decision to take the patient to the cath lab for an EP study based either on a strong suspicion for a slow heart rate, or the patient actually complaining of a very fast heart rate. And we don't really know the underlying cause or the nature of the fast heart rate that the patient's having. Cases with slow heart rate are most of the time we're doing an EP study to figure out what we call the HV interval. It's what we measure or we decide on to implant pacemakers for these patients. Of course, it's for risk stratification. People who have a very prolonged HV interval will have a tendency to have a complete heart block or to develop heart block in the future, which might explain the patient's symptom. In which case, of course, the patient will be decided to undergo the implantation of a pacemaker. On the other hand, when we're dealing with fast heart rates coming either from the atrium or the ventricle, the procedure is most of the time coupled with the ablation part as well. So we start the EP study with at least 4 catheters inside the heart. These catheters will be placed in the right atrium, the coronary sinus, and the right ventricle and the His bundle region in order to measure the activation inside the heart coming from the sinoatrial node all the way to the AV node, measuring the delay in the AV node all the way to the right ventricle. This will allow us to determine the nature of the fast heart rate, either it's coming from or being driven by an accessory pathway or being driven by an nidus inside the heart that is responsible for the activation or abnormal activation of the heart, resulting in a tachycardia. On the other hand, when we are doing a risk stratification, right ventricular pacing, we're actually trying to induce the patient to go into a fast heart rate, a ventricular tachycardia, in order to decide whether this patient is a high risk, in which case he will end up having an implantable, automatic implantable defibrillator, or in case we couldn't induce the arrhythmia, to go only with medical therapy. Of course, we see these scenarios on people who have an ischemic cardiomyopathy, for example, with their ejection fraction in the range of 40 to 45%, which will not be a guaranteed ICD implantation indication. However, these people can have sustained ventricular tachycardia, resulting in them experiencing syncope. This is a very common scenario where we actually use the EP study in order to risk stratify the patient. In addition, in channelopathies patient, especially the Brugada syndrome, I think there is a role for EP study for risk stratifying these patients as well. So, as I said initially, this procedure is done under local anesthesia. The patient most of the time will be consented for the EP study and the ablation coupled with the same procedure. If we found a nidus for a triggered activity, we'll ablate there. If we find an accessory pathway, we'll ablate the accessory pathway, and it would be a curative procedure for the patient. It's a relatively low risk procedure. Most of the time we're talking only about local hematomas, which are extremely rare since we are using ultrasound guided punctures. I've never seen over the last 3 years a single hematoma in our center. Of course, we can have a chamber perforation like indentina tamponade. This is an extremely rare complication doing an EP study. It would be like 1 in 5,000. Inducing a malignant arrhythmia which cannot be stopped, resulting in patient death. It's just, something that can happen potentially, but as I said, it's an extremely rare scenario. So to add up or to summarize, EP studies are used either to diagnose and fast heart rate, which we call the tachycardias, or to undercover the slow heart rate or a potential slow heart rate that the patient is experiencing, resulting in him losing consciousness completely. It's a very safe procedure, which is normally coupled with the curative option of ablation when we are dealing with tachycardias. Thank you very much. Wish you all the best.